This has been a terrific discussion. We've reviewed a lot of important information surrounding the treatment of renal cell carcinoma. Before we end this discussion, I'd like to get some final thoughts from each of our panelists. And really what I'd like you to share with our viewers is your excitement for the near-term and longer-term kidney cancer patient and our opportunities for those people, because kidney cancer remains an important disease. Obviously, we've committed our careers to that, but an important training ground for asking and answering high-quality experimental questions. David, you go first.
So from my perspective, I think the hope that I have over the next 6 to 12 months is that we'll see a PD-1 agent approved for use in our kidney cancer patients. Not because it's going to help the majority, but it's probably not. But there'll be a subset that get a prolongation, we hope, of survival, and as importantly, and I think more importantly, there'll be also a small subset of patients, as with IL-2, that gets a durable remission of their disease, meaning not just prolonged benefit because they stay on the drug, but benefit that lasts after they stop the drug. And so you could think of it as almost treatment-free survival, which is really what our patients are looking for. They want a chance to come off treatment and go back to their lives. And with immunotherapy, occasionally, some would say rarely, that can happen. And in my mind, the advantage of PD-1 is that IL-2 benefit, which we've seen for 20 years, could then be applicable in the community. So folks don't have to come to centers to get that small chance. But ultimately, we shouldn't be over-hyping what we're going to see. It's still going to be a subset of patients, and we shouldn't be promoting the global use of these agents because they're going to be expensive and there's going to be side effects. So we should still be focusing on the same thing. How do we identify the patients who are going to get that long-term benefit so that the right patients can get that right treatment? Because most patients are going to need something else. And hopefully we'll have some new options there as well.
Eric?
I think it comes down to figuring out, as David said, who's benefiting, why, and what can we do then to get the next group of individuals to benefit from these new immuno-oncology agents. And I think that properly designing clinical trials where we actually generate preclinical data that allows us to start answering those questions is going to be critical in the next 5 to 10 years.
Right.
And so this is what we need to do. I think that it's possible that the incorporation of anti-angiogenic therapies with immuno-oncology agents can then get that next group of individuals to become major beneficiaries. And then obviously combinations of immuno-oncology agents. So I think it's really exciting, but we need to do it right.
Right, absolutely.
Yeah.
Tom?
I think I agree with all the comments they made. We have new agents that are coming that seem to be quite powerful, but they're not generalizable. And so it just speaks to us to find predictors of response.
And I think for my own view, it's the recognition that we all stand on the shoulders of our patients. Mm-hmm. When they enter a clinical trial and we can ask and answer high-quality questions, we help the next generation of patients. And our practicing physicians in the community, the extent that they can be involved in these questions and answers, are going to speed the time to where we have longer progression-free survivals, longer overall survivals, and better opportunities. On behalf of our panel, we thank you for joining us, and we hope you found this Pure Exchange discussion, practice update on advanced kidney cancer to be both useful and informative. Thank you.